Hello, everyone. This is Chadi Alraies from RSH 2025 in Riyadh. I'm really privileged to be with Dr. Nadira Hamid to talk about imaging-guided decision-making for tricuspid valve transcatheter therapies. Nadira, thanks for being with us again.
Thank you so
Nice to see
much,
you in
Adi.
Riyadh.
That's right.
Yes,
We're finally meeting in Riyadh.
I know, from Denver to Riyadh. Yeah,
That's right.
yeah. So your talk is great and it's very
Thank,
practical
thank you.
because during the conferences we focus on the technique and how to repair things,
Yeah.
but I think how to plan for a procedure and which candidate for it, it is important. So
Yeah.
let's walk through the imaging guided decision making for tricuspid valve.
Right. No, that's a great question. I think everybody during the session realized that imaging is so important, especially in patient selection for which therapy, whether it's surgery, whether percutaneous options of tear therapy or replacement technology. And in this session, bringing out, I think I came up with a mnemonic, which I've used with my fellows. It's called GALIO. So thinking about G gaps, anatomy, thinking about leads, presence or absence of leads, and then imaging. Because if you have a poor imaging pre-procedurally, what are the things that you could do to improve it during procedure? Do you need ice, the presence of horizontal heart, simple things like that.
Yeah.
And also the other thing of O being others. Don't forget about the RV, the right ventricular function, the pulmonary vascular resistance, and also the left-sided heart disease, if the presence or absence of mitral regurgitation of aortic stenosis.
Right.
So GALIO is kind of a mnemonic.
Like
Yes, there was. I came up with it when about at least 3 years ago in New York, and it was during my trip to Safari. I think of the big 5 for success.
Nice.
And I thought of these 5 things when you screen a patient, during the TE process.
Absolutely.
As to decide what are the things and factors to affect in terms of which patient selection, whether it's a replacement, tear therapy, or even surgery.
So let's talk about what are the imaging features that will tell you this is not a good candidate for catheter therapy.
For transcatheter, am I right?
For transcatheter, yeah.
Yes. So, I think the option of tear and replacement, I think, has grown so much with the experience of operators. So thinking of gaps, if it's amenable to tear therapy, I think we've seen the data that tear therapy is safe, as effective. So certainly tear, I believe in a tear therapy first world, as a first line. But certainly if the gaps are not approachable, complex anatomy, then you're thinking whether is it a suitable replacement technology. And I think with the experience of operators and imagers now that we have across the continent and now around the world here, even in Riyadh too, thoroughly impressed. They do great work here. And I think, in terms of, we want to get the best outcomes for these patients, right? With
Absolutely.
RV reverse remodeling.
Right.
And so I think we have the options now with technology to get the best outcomes to decide whether is it a tear or replacement technology.
Yeah.
And I think that patient selection is really important. And I think if there's not any option of these two, you're thinking about heterotopic cable implants.
Right. Nadira, during the procedure, is there any imaging features that will tell you have to change a strategy or approach to the repair or replacement?
Yeah, no, great question. I think during the procedure, especially when the patient's on the table, is very different from pre-procedural. So the images may change. So to optimize the imaging, I think that's key. The heart may be horizontal. If you have difficulties in seeing the imaging in the mid or distal esophageal views, you have to think of other alternatives like 3D eyes. Be prepared, and that's where you communicate with your interventionist.
Right.
Hopefully the transgastric view is good, and so that can help in the process as well, in the workflow. And that's when you will work with your interventionist and communicate, all right, so once we bring down the device, we'll go to the transgastric view, and you can actually park the transesophageal echo in the transgastric view and then just image with the ICE imaging. Right. And that's what we did in the case last week. Yeah. So that's what I did because your mid-esophageal view was difficult. So I parked my TE probe. So you have less manipulation in the esophagus, so hopefully less damage as well. But that workflow of toggling between your TE and 3D eyes, it works really well.
Yes, yeah.
It looks really well.
Perfect.
And then with 3D eyes, I think, to improve the efficiency, that's what me and my colleagues, came up with the 3D navigation maneuver and help to optimize imaging of the clip arms. And so you get the best view with confidence that you are grasping the leaflets, and we have the tissue bridge and with TR reduction.
That's great.
So
Final question is about there's a lot of challenges, or if there is a lead induced TR, there's certain concept or maybe misconcept that you shouldn't touch a TR induced by the ICD or the pacemaker wire. So, is there any imaging feature that tell you this patient might be a candidate for therapy?
oh, great question. I mean, CID related TR is really challenging in terms of which therapy. I think for TriClip is always safe as well and effective. Presented a few cases, we've done quite a number of lead related CID related TR with TriClip, as long as you see where to clip. So you need the imaging views of finding the treatable gaps. And then you can do maneuvers as well to move the lead out of the way. So you have the Gillis maneuver using a Gillis or Oscar, moving the lead on fluoroscopy to posturoseptal. So you can put a clip in the anteroseptal region, and provided that the lead has some slack. So I think on fluoroscopy as an interventionist, you are able to tell as well whether you are able to move and it's not really stuck onto the leaflet or the subvalvular apparatus.
Yeah.
And you can clip as long as you can see with treatable gaps. We've done a few cases. And then, the other option of replacement as well, right? Making sure that, CT shows good. And then the most important thing I think in CID related TR is working with your EP colleagues as to what is the best option for that patient, whether thinking about lead extraction, if that's a possibility as well, and what are the risks, if to perform that, you want to go to someone who is experienced with lead extraction because it does has its complications.
Right.
And then what do you do after that, the lead extraction? What are the alternative? Whether is it a leadless pacemaker, and now there's so many options of leadless pacemaker. And I think for these group of patients is really challenging and very complex. Working with your EP colleagues really, really key, because you do have complications with jailing the lead, as you know in the literature. The TR, in terms of TriClip as well, and then lead extraction. So there's a lot of options for these group of patients, but I think it's still a learning curve for all of us.
In the past, or in the aortic space, usually we ask for EP help after the fact. But it
That's
sounds
right.
now the EP becoming part of the heart team for planning of the procedure. It's getting
Absolutely.
more kind of more broad and covering more specialties.
That's right.
Well, Nadira, thank you so much for a very insightful interview about imaging approach for patient with tricuspid valve and
Thank
what's your
you.
best therapy for it. Watch it videos and others on your YouTube channel and the website. This is Shadi coming to you from Riyadh Structural Heart Conference in 2025. Nadira, thanks again.
Thank you very much,
Thank
Shadi.
you.